as we enter the 21st century, we have a gamut of anti-VEGF injections available with us, which are targeted towards decreasing the macular edema secondary to the epidemic of diabetes mellitus type 2 in the whole world. India is the next capital of diabetes mellitus, and yes, we as vitreoretinal experts and phaco-refractive surgeons need to have a profound knowledge of which anti-VEGFs we should go for in cases. So I would recommend being a good phaco-refractive surgeon is incomplete if you don't know the correct technique to inject a anti-VEGF. So we'll be injecting an injection Ozurdex, which is the drug of choice for CRVOs and BRVOs, especially in the recalcitrant edemas. We'll take off the safety pin. I'm just showing you the injector so that you know what injector looks like. This blue part of the needle is a marker for you to, it acts as a barrier when you go ahead and pierce that scleral shell to inject the syringe into the vitreous cavity. So I have slowed down this video, and for my protocol, the most important thing in an intravitreal injection to note is the betadine application on the eye. My protocol says I apply betadine 3 times to a patient. The first round goes 10 minutes before the injection, the second round is 2 minutes before the injection, and the third round is just before I apply the injection. So 3 times I apply the betadine. I don't dilate the pupil. I ask the patient to look towards their shoulder so that I can inject the injection in the supratemporal area. Some surgeons prefer to inject it in the intratemporal region, but my choice is supratemporal. For phakic patients, I take 4 millimeters of distance from a vernier calipers from the limbus, and in the pseudophakic patients, I prefer to use 3.5 mm of the distance from the limbus. These are the standard guidelines for an injection, and what I have noticed in my experience is it gives the best results if you displace and drag that conjunctiva with a dried swab stick, and then you inject the injection tangentially. Mind you, tangential going inside the vitreous cavity is the way to go. So right now I have slowed down this video for you to notice the characteristic details of the injection. So I have dragged the conjunctiva, I have kept the bevel up. Notice, bevel up. My fellow surgeons and juniors, keep the bevel up. Perforate the globe tangentially. Yes, tangentially, so that the tract of your injection is somewhat oblique to the globe. And yes, I have shifted the position of the needle perpendicular to the, and as you can see, just look at the pupillary area. You can see the intravitreal implant, which is a small cylinder made up of triamcinolone. Is it triamcinolone? No, it is dexamethasone. Ozurdex is dexamethasone implant. So I have just kept this betadine soaked swab stick. I have just put it on the tract so that it seals up well. There can be minimal prolapse of vitreous as well, but don't worry, it won't hurt the patient. Yes, I have just sped the video up, and as you can see the Ozurdex implant if your technique was right, even in a small pupil like this. I consider this video very important in your early days because everyone should know how to inject an anti-VEGF. That's all from my side. I hope you like my videos. Thank you.